Hi everyone, we've got another video for you today. We're going to be talking about unexplained hypercalcemia. So the aims of this session are to understand the differential diagnosis of hypercalcemia. We'll talk about the mechanisms as well, talk about how we approach the diagnosis and the different tests we need to do, and talk about management. We'll make this generalist rather than overly specialist. So we're going to start with our case as usual. We're going to meet Karen. Karen's 53 and we're seeing her in AMU. So she's been referred by her GP because she had some abnormal test results from bloods taken yesterday. So she's seen her GP with fatigue and a backache. The GP actually took the patients because they thought she looked a bit dry, a bit dehydrated, so they've sent off a blood count and a biochemistry screen. And biochemistry's come back with a calcium of 3.6. That's a hurried call from the GP to the hospital and to the patient comes in. And now you are in charge. Just a couple of things to consider before we start looking at the history is it's good to have an idea of a differential when you see the patient. So we know that she's been referred in with a high calcium. So when you approach the history, you want to have an idea of the different possibilities because it will help target your questions. So especially we can focus on the important differentials to consider early on and how to figure out whether it's likely to be one of those differentials. Then we can look at how these ideas are going to be supported by the blood tests we look at afterwards. So before we dive in, let's just have a quick recap on the calcium cycle in the body. Don't worry, I won't go into too much detail. So your dietary vitamin D, which is activated by sunlight, goes in a two-step stage through the liver and then the kidney. And your end result is calcitriol. That's the active form of vitamin D. And that acts to increase dietary absorption of calcium from the gut. Your parathyroid hormones sense the level of calcium in the blood in a negative feedback system. So if there's low calcium in the blood, then more parathyroid hormone is released. That has several actions to improve the calcium level. And conversely, if the calcium level in the blood is too high, then the parathyroid hormone levels should drop. At med school, many of us will have been taught the classic acronym Bones, Stones, Moans and Groans is a way to easily remember the symptoms of hypercalcemia. We're going to go for a slightly more in-depth approach here. So we're going to consider the neurological symptoms, which range all the way from impaired concentration through confusion and mood disorders all the way up to coma. When we look at the musculoskeletal system, we have weakness and bone pain, and osteopenia and osteoporosis. And it's not unusual to see fractures in this situation as well, especially in the elderly. If we turn our attention to the GI system, anorexia, nausea and vomiting, constipation. So have a think about the effects of calcium on muscles, explaining both the skeletal muscle as we explained above with the weakness, and with the sluggishness of the bowels, those effects on the smooth muscle. Pancreatitis and reflux disease are also seen. If we go to the cardiac muscle now, we see bradycardia, high blood pressure and a shortened QT interval. We'll see some ECGs in a minute. And kidneys, so polyuria and polydipsia, and that's the calcium bringing a fluid load out with it as it's excreted. You see kidney stones as the calcium precipitates in the renal tract, and this can all lead to chronic and acute renal impairment. We can divide severity into mild, so 2.6 to 3, and this is often asymptomatic. Moderate, which is 3 to 3.4, where you need to start paying some pretty close attention. And severe, we're talking emergency, do something now type situation, above 3.4. And remember, what you're looking at on the blood test is the adjusted calcium. This takes into account the serum albumin. Remember, patients with very low or very high albumin may have abnormal calcium results, and that's because albumin binds serum calcium. So, your turn to do some work. Just think of 5 diagnoses that are springing to your mind right now with this lady with a calcium of 3.6. So, differentials. The way I always start with hypercalcemic patients is, do they have primary hyperparathyroidism or malignancy? And this will account for 90% of your cases. So your PTH affecting syndromes, 85% of them will be a solitary adenoma in one of the 4 glands. Others include carcinoma, hyperplasia of the gland, or the rare MEN1 or 2A syndromes. That's multiple endocrine neoplasia. With the PTH-related diagnoses, especially the adenomas, it's often a more slow-burning syndrome. So the symptoms will appear over months and will be less severe. The patients seem to tolerate them better, probably because of the chronic nature. So malignant causes tend to occur a lot more rapidly, so a shorter time of onset, and because of that acuity, the symptoms are often more severe. Various mechanisms. We can have a paraneoplastic syndrome, so parathyroid hormone related peptide can be secreted by various cancers. That will have the same action as PTH, so increasing the blood calcium. We can have direct invasion of the bones, so metastatic breast cancer, for example, or the lytic lesions in myeloma. And less commonly from the vitamin D pathway, so examples of this is Hodgkin's lymphoma, and the same mechanism is also found in granulomatous disease, and that's where macrophages are activating vitamin D, and they're doing a little bit too much of that, increasing the absorption and reabsorption of calcium in the body and increasing the serum levels. Other causes, we won't go into these in too much detail, but we'll have a quick look. So various drugs, really important to do a thorough drug history. The main offenders are lithium, thiazides, which can affect the reabsorption, people taking over-the-counter vitamin D or calcium supplements. Those, especially combined with antacids, can push that calcium up, and vitamin A is another one. Take a good history for any autoimmune or respiratory symptoms, thinking about sarcoid, TB, leprosy, and so on. And a family history for familial hypocalciuric hypercalcemia, which I won't go into in this lecture. We can look at renal causes, which should be apparent when the patient comes through the door. I'm looking at their initial blood tests, so if they've got chronic kidney disease, they can develop tertiary hyperparathyroidism. We can have other endocrine causes as well, so hyperthyroidism, Addison's, and very rarely pheochromocytomas and VIPomas. And as with the other causes on this slide, these tend to be less severe than your PTH or malignant causes, i.e. the calcium tends not to be above 3.4. And lastly, immobility. So especially in younger patients that have suddenly become immobile, you can see that calcium creep up. And Paget's disease, whilst not traditionally associated with a high calcium, in some cases it can push the calcium up, especially if the patient is immobile with it. So let's turn our attention back to Karen. So her history of presenting complaint, she's had 3 weeks of increasing fatigue, she's thirsty all the time, she's got back pain and is constipated. So these all go fairly neatly with standard hypercalcemia. Of note, she's got no weight loss, sweats, fevers or lumps. But the one thing I'm really interested in this part of the history is this, the 3 weeks. Quite a short history, and that would make me worry. In her past medical history, she's got a background of reflux and gallstones, for which she takes omeprazole. No family history, smokes 10 a day, works in a middle management job, husband, 2 kids. Examination normal, so heart, chest, tummy, nothing particularly interesting there. Karen's blood tests. Full blood count looks alright to me. Use and ease, probably a bit dehydrated there, high urine creatinine. LFTs look okay. And the bone profile, we're expecting a problem here, aren't we? Corrected calcium 3.6, there we go. Phosphate 0.9. So what else do we want at the front door? Just have a quick think in your mind now. What do you want right at this second for this patient urgently? I would like an ECG just to make sure I've not got any life-threatening arrhythmias on my hand at this point in time. And at this point we can send the PTH. You won't get it back immediately, but get it done. The sooner you send it, the sooner it's back. So the ECGs, I've got 2 example ECGs here. The first one demonstrates a shortened QT interval. This one shows a more severe picture. If you look at V1 especially, you'll see the J wave, that notching on the QRS complex on its way down. Investigating these patients, we send off the PTH, and the result of that is going to dictate really one of two diagnostic pathways, along with your history and examination, of course. So when you've got a high PTH, this is diagnostic of primary hyperparathyroidism. When it's normal, even at the lower range of normal, primary hyperparathyroidism is still the most likely cause. That's because a high calcium in other causes should suppress the PTH. That's a normal response. It's appropriate. If the PTH is normal with a high calcium, that's inappropriate. That shouldn't happen, and that tells us that there's most likely a PTH problem. When you investigate these patients, examination, neck lumps rarely palpable. You can measure the vitamin D levels, and these can be low. And do be aware, on the other hand, that low vitamin D by itself can increase the PTH level. Your phosphate will usually be low with these patients. You can do a DEXA scan to look for any bone disease, osteopenia, osteoporosis, as we mentioned earlier. And planning for surgery, if the patient's fit for it, we can do further scanning, ultrasound, CT, MRIs. We often combine this with technetium system EV. And this just helps localize the adenoma or whatever it is you're going to cut out. On the other pathway, we've got low PTH, or normal with a convincing suspicious history. So if you're suspecting malignancy, we need to go hunting for malignancy. So at the bedside, you can do breast examinations, chest x-rays, that sort of thing. Maybe tempted to do a PTH-RP assay, that's a related peptide. These are actually rarely done. The focus should be on finding the cancer. We can do an endocrine screen, looking for thyroid function, steroid, vitamin D, so looking for the other causes. If there are weight loss, night sweats, fevers, then think about tuberculosis, the various tests for that, and scanning for lymphoma or sarcoidosis. And consider doing a myeloma screen. And in a lot of these patients, you may well end up doing some 3D imaging with a CT scanner. So let's turn our attention back to Karen. Her PTH was normal, the ECG was fine, lymph nodes were all okay, neck, axilla and groin, breast examination normal, chest x-ray showed a spiculated lesion in the left lower lobe. Suspicious. So you need to do a CT scan pretty quickly and get a biopsy. You can also consider doing a bone scan as well. Biopsy was done, showed squamous cell carcinoma as a primary. Remember, it's going to take quite a few days to get that result. A scan showed no metastases. So what do you think might be going on here? There's nothing eating away at the bone. So this is probably PTH-related peptide, so a paraneoplastic syndrome, which is associated with squamous cell carcinomas. So, management of these patients. So we're going to roll it back to AMU. She's come in, you've sent your initial tests and got your ECG, and now you've got to do something about it whilst we wait for those tests to come back. So your basic management for these patients is going to be to stop any of the drugs that could be causing a problem. So that's your thiazides, your lithium, your calcium and vitamin D supplements, and you're going to rehydrate. So the standard and the trust guidelines is 3 litres of sodium chloride over 24 hours. Of course, if your patient has severe heart failure or renal disease, we may need to reconsider that. But for the vast majority of patients, this should be fine. There is stuff in the literature about hyperhydration and furosemide used to be used. That's less common now because it doesn't seem to work any better. So for now, we just stick with the 3 litres over 24 hours. At the 24-hour point, if your calcium's still above 3, you carry on your rehydration, and now it's time to add in a bisphosphonate. The choice depends on whether the patient has a malignancy or not. If they've got a known malignancy, there is some evidence that zolendronic acid is the better choice, but either can be used. And your dose will depend on the calcium level, so do check the BNF. It takes about 3 to 5 days for the bisphosphonates to work. So which is why I've put here at 4 days. If you're not getting any reduction in calcium, or if you're not sure what to do, you will need specialist input. And there's a good chance you'll have consulted an endocrinologist before this. So that's the mainstay of therapy. There are other therapies to use, particularly in difficult or refractory cases. So in patients where bisphosphonates aren't appropriate, so if they're contraindicated, say severe renal failure, then you can consider denosumab. And this is a monoclonal antibody that affects the rank-1 ligand. In certain conditions like lymphoma or sarcoidosis, you can use steroids, and this reduces the macrophage activation of vitamin D. So that can help bring that calcium down. In acute severe hypercalcemia, we can use calcitonin. So this is a naturally occurring peptide which we can give exogenously. What this does is it interfere with osteoclast activity and reduce calcium absorption. It's useful for about 48 hours. After that, patients can start to react to it. So it's a stopgap measure for acute severe cases. And in really extreme cases, you may consider dialysis. This is patients with heart failure, renal failure, or really, really high calcium. So there we have it. Bit of a whistle-stop tour. It's quite an in-depth subject, hypercalcemia. So I would recommend doing a bit of further reading. So there's two fairly succinct UHL guidelines, one on malignant and one on non-malignant hypercalcemia. And you can access them online or use the Doctor Toolbox app. Up to date's got 4 different articles on hypercalcemia. They're all pretty useful, so have a look at those. Or for a quicker summary, the BMJ best practice is very good. And those are all accessible using Insight, so you've got free access. Thank you for listening.